Hello, everyone. I'm Troy Skubitz, the Senior Manager of Events and Education for CorneaGen. Thank you for participating in today's webinar titled Think Outside the Cone, a Refractive Approach to Keratoconus. The format for today's webinar will be conversational between our moderator, Dr. Arun Jordan, and our guest, Dr. Arun Gulani. During today's webinar, you will learn about the full spectrum keratolenticular refractive approach to your keratoconic patients. Say that 5 times fast at home. Where intact corneal implants fall in the treatment spectrum, stabilizing the cornea before and after ocular surgery to optimize vision outcomes. And then we'll look at a couple of keratoconus cases with Dr. Gulani. We will use the last 10 minutes of the webinar to answer questions that you have. You can submit a question anytime during the webinar by using the questions box in the upper right-hand corner of your screen. Click on the plus sign. It will open a text box for you to write and send your comments or questions. We'll do our best to answer as many of them as possible during our allotted time. Now, let me tell you a little about today's moderator, Dr. Arun Jordan. Dr. Jordan is board certified by the American Board of Optometry. She completed her training at Bascom Palmer Eye Institute and graduated with the highest clinical honors. Dr. Jordan specializes in cornea and refractive surgery and has over 10 years of experience in clinic managing patients. She worked at Bausch & Lomb as executive clinical outcomes specialist with their premium IOL portfolio and later transitioned to AcuFocus Inc. Dr. Jordan now works for CorneaGen as the Director of Medical Affairs and Clinical Education. I'm happy to have my colleague, Dr. Arun Jordan, moderate tonight's discussion. Welcome, Dr. Jordan.
Thank you for the kind introduction, Troy. I'm extremely pleased to host tonight's discussion with our guest speaker, Dr. Gulani. Before we start, let me tell you a little about him. Dr. Arun Gulani is a world-renowned eye surgeon, award-winning inventor, author, and international teacher whose pioneering surgical techniques and innovative concepts draw patients and eye surgeons from all over the world. For over 2 decades, his Think Outside the Cone concepts encourage eye surgeons and eye doctors of all categories to change their mindset in taking keratoconus patients straight to vision using single or stage surgeries, custom designed for safe and stable visual freedom. Dr. Gulani, thank you for being with us tonight.
Thank you for having me, Eric. Good evening.
So I had the pleasure of visiting Dr. Gulani's state-of-the-art clinic a few months ago. And as we were discussing his innovative approach to patient care, what truly captured me was his disarming and unique style of the very nuanced disease of keratoconus. As someone who manages keratoconus patients myself, I found his view of the disease, from educating the patient to the eventual treatment path, to be refreshing, a view of keratoconus through the eyes of a creative, if you will. I suppose this is a good starting point for tonight, Dr. Gulani. Tell us what you mean by thinking outside the cone.
So first of all, Eric, it was a pleasure having you. And as you know, my whole approach to eye surgery itself is holistic. That's why I've coined the term CLEAR, or keratolenticular extended armamentarium refractive surgery, meaning we have all these techniques and technologies available. Let's not limit ourselves by thinking of technique first. Let's look at the patient and look at visual potential. So think outside the cone is my rhetoric for our colleagues, but I encourage them to not get baffled or paralyzed by this very word keratoconus. These patients actually can see, and in most cases, I said most cases, can even reach 20/20 without glasses or contact lenses. Now, at the outside, let me be very clear. This is not a guarantee you make to any patient. These are, of course, more difficult patients to work with and plan. But our mindset has to be, let's aim for that goal, right? So with that, let's understand what think outside the cone means. Majority of the time, as it's been taught in the books, keratoconus brings into us a concept of, oh, this is really out of the realm of any management. Let's either avoid a transplant or let's stabilize the cornea. Well, that's not the patient's request. The patient is saying, I want to see. So that should be the bottom line, the underscored bottom line that I want to keep on pressing throughout this webinar. And the think outside the cone is our end point of this webinar, where may I encourage all of you to open up your minds, absolutely believe that each and every keratoconus patient of yours can see. And how do we take them to that vision? Another point I'd like to point out here is, please do not get so involved and consumed in grading keratoconus with mathematical indices that you really lose track of vision. The reason those two topographies have been sent to you by CorneaGen are some of my patients, where my main reason to share with you was, even with these 23 diopters irregular astigmatisms, you can bring them to 20/20 without glasses. So I don't even agree with the concept of mild, moderate, advanced. Every patient of keratoconus, let's believe they can see, and then let's get to work and design their vision. That's my concept of outside the cone.
I appreciate that. And so talk to us about the S system that leads to success, or in your words, the mental sorter as it relates to keratoconus.
Absolutely. That's a great word. I keep using mental sorter, meaning what I do here for our colleagues over on the webinar tonight is I refuse to let these words weaken my knees, if you may. Keratoconus, LASIK, ectasia. Please, let's keep those words aside because they create a scare and loss of hope. Let's in fact break them into this 5S system. Practically any situation of pure refractive or refractive complications that you may see in your everyday practices has to be able to go into the S system. So if you look at the first S, it says sight, S-I-G-H-T. What that means basically is, does the patient have potential to see? If they have potential to see, we as eye doctors, all levels, ophthalmologists, optometrists, opticians, must fight for that vision because the patient has potential. So that's where I break it down into, on the slide you see, improves or does not improve. Next is scar. Does this patient have a scar in the cornea? Now, if there is a scar, we have to do something about it because it's in the visual axis. Let's go to shape. If you think about it, even your routine refractive patients that come into your institute or practices are nearsighted, farsighted, or astigmatism. It's all about shape, right? Myopia is steep, hyperopia is flat, astigmatism is football shaped. Irregular shapes can exist, and we'll talk about that. Strength. If the cornea is thin or thick. Thin meaning if they are less than even 500 microns. And again, I don't care for that number. Having done thousands of cases over 3 decades, I will give you numbers in the next webinar. Right now, we're just changing our mindset. So let's call a thin cornea less than 500 for our discussion. Thick cornea more than 600. So thin or thick will decide what you do with the cornea. Sight, S-I-T-E, is the central affliction of the cornea or peripheral affliction, meaning scars or irregularities. If it's in the periphery, it doesn't bother you as much. If it's in the center, we need to do something. Now, any of you cannot present any patient to me that cannot fit this 5S system, whether it's a routine eye or it's a very, very complex eye, you think. And we can go through this later when we're talking about planning these cases. So let's even, just while we're on this slide, let me finish by putting a keratoconus patient into the 5S system. So SIGHT, surely these keratoconus patients can see. If we still don't believe, let's put on a hard contact lens on them and then make them see. So we know there is potential. Scar, many of them have central scar, many of them do not. That decides what we do with the cornea. Shape, most of these keratoconus have myopia and they have astigmatism, mostly irregular astigmatism. So that's a shape anomaly. Strength, most of the keratoconus are thin cornea. We know that. High keratometry, thin. Site of involvement usually is the center, so that needs to be tackled. So you see, when you look at the 5S system, literally it unfolds into a plan of approach. This way, we will never be subjugated or held ransom to a surgery or technology. You're always free with unlimited abilities. So that is my conclusion of this slide and 5S system. I call this the brain of my practice, literally.
So, and I assume that you use this classification system to also not only just sort of categorize keratoconus, but essentially map out treatment for these patients as well. Could you give us an example as to how one of these particular categories would lead you to one particular type of treatment versus another?
Certainly. And let's focus in this webinar only on keratoconus, right? This can be applied to any level of corneal problems or complications of premium surgery. Let's focus on K-conus. So let's say a patient has keratoconus. Let's say the patient is highly myopic, has a central scar, and of course the strength is thin, right? Now let's go to sight first, SIGHT. In my practice, I personally refract every patient, no matter how far they've flown to me from. I will personally refract them. You'll be surprised if you do that. You see the potential of vision in so many patients where a topography may have misled you into making the case look horrible, if I may use that word. So I do not look at topography. I start with refraction. That to me is the gold standard of vision. Remember, a refractive surgeon must follow refraction. Okay? So in the sight action, SIGHT, most of these patients do have sight, which means we must do something to help them. Now, let's go to scar. Let's say they have a central apical scar common in keratoconus. Let's say in this case, there is no scar. And let's go to shape. Irregular astigmatism, let's call it 6-diopter astigmatism, and let's call it hyperopic astigmatism. Let's go to strength, it's thin, site of involvement, central. So my plan in this particular case would be, I want to do something that can correct my astigmatism, strengthen my thin cornea, decrease my keratometry. Remember, there's no scar. I'm not concerned about that center. And I know there is potential to see. Now, the one surgery that comes to mind right away would be lamellar keratoplasty. We remove a layer of the cornea, put a layer of cornea or dowel, and now you have addressed the central thickness. You addressed the central shape. Problem is you haven't directed astigmatism. You just replicated it. So instead of a lamellar keratoplasty, the surgery I would do here would be intact. I would put a ring on this steep axis. Again, there is a way to do it in different cases. With that insertion, I have done the following things I wanted. I gave the cornea more strength because the intact is a brace in the cornea. I arranged it on an axis, so I actually correct the astigmatism while I'm giving strength. Third, it's also decreasing the keratometry. So you see how you bring all this together and you take the patient to vision. Now add a scar to this, make the cornea much more normal, let's say in thickness. You can even do surface laser surgery in these cases. I have criteria for that. We'll discuss that later. Now, any of these cases, you can cross-link after you have corrected the corneal shape. So does that explain, Aris, where I'm going? Now let's go a little deeper just to end this conversation. Let's say this patient also has a deep scar and the cornea is less than 250 microns. And you cannot measure anything, no matter how much you try. Even a hard contact lens, you're stuck. Now you're talking lamellar keratoplasty. Shave off the top layer of the cornea, put in a 2/3 thicker lamellar cornea, anti-torque running suture kept for 3 months. Now you have corrected the scar, added thickness, which is strength, corrected the shape, and corrected the entire center. Now, 6 months from now, come back and do laser on the surface to correct astigmatism, or ICL if it's high myopia, or if the patient is over 58-60, you can even do a toric lens implant. Have I made myself clear, Eris? See how the plan moves?
Yeah, that's great, and I appreciate the hypothetical situations here, as I think it's important. One final thing before we move on is I just wanted to, because I find that it's a unique approach. How do you go about educating the patient? And let's just use this particular hypothetical case in what these steps are, as some of them are sequential, and how do you prepare the patient for that visual journey that they're about to embark?
So surprisingly, I exactly say and talk the same language. I don't repeat myself. And you'll be surprised, many patients get it immediately because it's logic. You tell the patient what's going on with you, all right? Again, I tell them you have keratoconus, but here's how I define keratoconus. It's a relatively thin cornea with high keratometry, most usually myopia associated with astigmatism, sometimes a scar. That's it. You see how we broke down this giant into small Snicker bars? Now, you attack. You tell the patient, here's how I'm going to approach this. I need to think of some way that I can strengthen your cornea, give it a better shape, because shape is vision. Remember LASIK we do for shape? Yes, doctor, I get it. Perfect. In this case, we can't do LASIK and stuff because your cornea is weak. I need to strengthen it. I need to clear the center. I need to improve your shape. And if needed, optically manipulate you depending on your intraocular status. They get it. Absolutely get it. I have yet to find a patient, and I see them from all over the world, someone who doesn't get this. And in fact, they're confused when they come to me with diagnoses which are half paralyzing. Oh, doctor, I have LASIK ectasia. I'm told I have no hope. No, you again have a high keratometry, thin cornea with high astigmatism and possibly hyperopia. So that is my way of explaining to patients. Here's another thing I use all the time with my keratoconus patients. I say, you are 11 feet tall. There is no suit I can get for you in the mall. Let me bend you down to somewhere close to 6 feet. Most of these surgeries are not accurate like LASIK. Let's say I'm doing intacs or whatever. I may bring you down to 6 feet. I may bring you down to 5 feet or to 7 feet. At least you have a chance of getting some suit in the mall. That is the concept. And they get it. Wow, doctor, so you get it. It's absolutely. Now, between me and my colleagues, I still want 20/20. So that's the difference.
Yeah, and you believe that's achievable with a lot of these keratoconus patients, because I know that our goal is to achieve functional vision, but 20/20 is quite a hefty goal. So that's something that you aim for nonetheless.
Between us, because as a doctor, if we don't try, same thing we were taught as kids, right? Aim for the stars. So why not aim for 20/20? In my personal experience, that's why I'm sharing this all the time with doctors, is I have numerous patients who are 20/20 without glasses, and they were all levels. Therefore, I don't agree with any early, mid, late, advanced keratoconus. Every keratoconus patient, of course, not all of them land on 20/20. That's where we have adjunct treatments, intraocular treatment, combination treatments, even specialty contact lenses like scleral contacts, which optometrists can do. So there are such modalities today that we can free up all our patients. At least we should try.
I believe that. So as we all know, nothing about keratoconus is a one-size-fits-all, and just to essentially echo what you're saying, but rather a customized, systematic approach that is unique to each patient. As you noted, we are all taught to pay close attention to the numbers, especially those generated by topography. Can you discuss with us what your assessment criteria and treatment plan looks like when you consider the subjective nature of keratoconus?
So you already answered my question. It's a very subjective scenario, and I look at keratoconus as an art, not as a mathematical approach that we do for our base refractive surgery in absolutely virgin eyes with no pathology. So when you approach this as an art, 5S system becomes your backbone. And the 5S system helps you look at how do we approach this, like we just discussed. In my own way of teaching, I call these corneal contour modification surgeries and corneal tissue replacement surgeries. That's my division of corneal surgeries for keratoconus. Now, what is a contour modification technique? All kinds of corneal implants, including your the ones from Europe that I also use sometimes, and the intacs we have here. These are contour modification, meaning you can modify the shape with these. Then corneal tissue replacement, anterior sutureless lamellar, anterior deep lamellar, deep anterior lamellar keratoplasty. All these are tissue replacement. Of course, there's penetrating transplant. We never want to get there, ever, in keratoconus patients, unless there is a perforating damage to the cornea, period. So if you look at the corneal aspects, now you'll start understanding what I mean by my CLEAR system, KLEAR. It's a keratolenticular refractive armamentarium, meaning you can use over 17 corneal surgeries, over 13 lens implant concepts, and if you combine all these, unlimited permutations to take every keratoconus patient to vision. In between is a concept of a super technology that is not new. It's over 2 decades old, corneal crosslinking, which should not be used unless you're stabilizing the cornea or after you have corrected the cornea, you permanize the outcome. That's how simple the division is of how I think.
Mm-hmm.
And therefore, when you approach these patients, here are the skills you need, which all of you have. All of you know how to do cataract surgery, which means you can do a phakic implant, like a toric phakic implant in keratoconus. You can do pseudophakic surgery. You can do a piggyback lens surgery. You can do lens exchange surgery. Those are intraocular. In the cornea, you can do anterior lamellar with a laser. You can do hand lamellar for deep, and you can do, of course, a penetrating lens. You can, of course, do intracorneal surgery like intacts and channel perfecting surgeries further down. And then you come down to, again, as I mentioned, the cross-linking or the permanizing of all these techniques. And most surgeons have these skills. Therefore, these patients absolutely get corrected.
Mm-hmm. So, Dr. Gulani, when we met, I deservingly deemed you the analogy guru, and this one happened to be one that resonated the loudest with me. Tell us about my favorite, the spine analogy.
Yes. So this analogy I teach a lot because every day I get questions from all over, from very brilliant colleagues, and I keep explaining the same thing. So I just made this slide. This slide explains to everybody how I look at keratoconus. Think of keratoconus as a bent spine or a condition that we know as scoliosis, right? Now imagine if you were just putting the red on the second portion of the spine shows cross-linking. Imagine if you are cross-linking every keratoconus patient. You're actually doing a disservice to the patient because you are permanizing their disability. Their spine will be curved forever. Instead, straighten the spine and then cross-link them. Like I said, permanize your surgery. So that takes away all the questions that anybody can have, how to decide when to cross-link. The only indications for cross-linking are a patient who's rapidly changing, either a young patient before 21 or even a patient beyond 20, 30, but rapidly changing that you just cannot decide what the refraction is. Again, let's not go into those patients who even at the age of 60 sometimes show changes. So I'm not discussing those in uncommon scenarios. Let's go to common things first. So cross-linking is for constantly changing cornea so you can measure. And the other indication I have is when you have corrected the cornea either by laser, by an intact, by a lamellar, something that you got them to 20/20 vision, go ahead and permanize them, cross-linking. Those are the indications for cross-linking. Simple, they are an adjunct, they are not a treatment. So please, please be careful. I'm seeing so many complications of cross-linking flying to me with vision deprived, scars, of course, a lot of them still changing, and the patient was told that this is a treatment. So patient, when they hear the word treatment, they believe it's vision. Therefore, they come out very disheartened and unhappy. The cross-linking is your way, is a very powerful adjunct to all the techniques we discussed just now, kerato, lenticular, refractive techniques. A very important adjunct, but it is not one of the treatments. It is a stabilizing factor for keratoconus. Does that explain this spine concept?
It does, and what I wanted to kind of go back to is what straightening the spine means, and does that essentially equate an improving functional vision for the patient first before we essentially lock in the effect? And what is improving functional vision? I know you touched on that just a bit, but perhaps you can kind of go into a bit more detail of what improving functional vision means, or what those treatment channels look like prior to considering that ceiling effect.
Certainly. Let's suppose someone has a beloved family member, let's say a child, and they have a scoliosis in the spine. Now look how it sounds as a doctor if you say, listen, there's this new cement that was just approved by FDA. I'll put it on your spine this way you won't bend anymore. Well, the mother is very impressed. That's great, doc. That's amazing. And then the father intervenes and goes, but doctor, won't my child be bent forever? And everybody's spellbound, but isn't that a factual question? So the scoliosis analogy, first fix the spine, unless you are stabilizing the cornea before you fix the spine. Now, fixing the spine is pretty much going back to what we discussed. Vision depends on the shape of the cornea. That's the basis of corneal or keratorefractive surgery. Now, to fix the corneal shape, we'll go into this later. Surface laser techniques that I worked on can be done for these patients, especially when astigmatism is more than myopia, and you're removing very little tissue because the excimer laser algorithm removes least amount of tissue in astigmatism and gives us a very large oval zone, which is excellent even for night vision in these patients. And I've done these and clinically seen these patients for over 2 decades. Second, go into the corneal contour modification that we discussed, whether it's the Ferrara rings, it's the Intacs, all these kind of intracorneal implants, straight in the cornea shape. Then you can go into lamellar area. So let's say after doing this, and then being able to do intraocular surgery, whether it's phakic implants, pseudophakic lenses, whatever, toric lenses, which I use a lot in K-corners. Now you can permanize this vision and crosslink them. This way you really took away their childhood disability. Now that's what working on these disability means. You just reversed their birth issue or birth defect and brought them to perfect vision.
Great. Thank you for clarifying that. And, I suppose in our world, there's nothing more powerful than proof of concept. So next, I'd love for you to take us through a clinical review of the 2 cases that you shared with us and we therefore shared with our attendees prior to the webinar. And once again, it's just, kind of sorting through numerical values and visual end goals. So I'll let you walk us through the very first case, and if you can kind of speak to what your treatment plan was and how you executed to the eventual outcome.
So as I mentioned, I will go through these cases in detail in the next few webinars, but here the reason for me to give you some of these among many I have was for our colleagues to look and understand that I do not believe in mild, moderate, advanced classification systems. That just paralyzes your endeavor, and these patients are desperate for vision. We must help them. Now, if you look at this patient, 23.5 diopter irregular astigmatism. Patient's cornea, if you see, is very thin. It's even down to 300 microns. So again, if you just looked at this topography, you'd be baffled. And you most likely, if you follow these grading systems that are being taught, you'll absolutely do nothing, which is what this patient had. For years, nobody did anything, 40 years. And finally, when I looked at her, again, I do what I do, which is refract them. You must refract them. I never look at topography until I have refracted my patients, even patients who come in for basic myopia, astigmatism, whatever. Remember, topography doesn't correlate with vision. Refraction does. So there is nothing more powerful than a streak retinoscope. I have 9 topography units because we are beta testing for a lot of industries from all over the world. But this is my key. Refract each patient. A refractive surgeon must know how to refract. So if that point is clear, here's what we did here. This patient actually had hexagonal keratotomy. If you remember, those were the hexagonal cuts in the central cornea to correct hyperopia. She was also with Fuchs dystrophy, hexagonal keratotomy, complete ectasia. The cornea you can see is at 88.9 diopter keratometry. Of course, she had been left with nothing can be done. No such thing. So again, look, I'm not giving it a name. Ectasia, hexagonal keratotomy, central, nothing. All I did is my 5S system. Does she have vision, sight? She did. When you put a hard contact lens, she was reaching 20/60 vision, which is amazing coming from 2400 and count fingers. 2. Was the center involved? No. Hex K was around the center. Remember, center is clear. The cornea was it thick or thin? Actually, it was intermediate, and here is why. It was actually thin because of ectasia, but because of Fuchs, it was thicker. So it was actually normal. So you see that? You see the thickness on the side? It can even come up to close to 500 in certain areas. Then, what else were my concerns here? So when you put in the 5S system, there is sight, S-I-G-H-T. There is central clarity, so I have to do nothing in the center. There is no SITE involvement. And because the patient has vision, the shape was very distorted. 23.5 diopters irregular astigmatism. So here is my thought process. And she's over 60 plus. She obviously has a PSC cataract, deep, extreme myopia, very high myopia too. So when I line up all these things, what I call this is for another topic, I call this lining up my pins before I roll the ball for the strike. You can't just roll the ball and say, God help me. That doesn't work. So when you put all the pins together and you count them, now your plan starts unfolding. So my pins were, I wanted something to stabilize this hexagonal cornea, which is a central island of instability. I wanted something that could also correct this astigmatism while I'm stabilizing the center. I also wanted this cornea to be so stable that it becomes what I call sensible or measurable, because I was planning to go intraocular for her PSC cataract too. So everything is a plan here. Now, when I sit back and I go to my kitchen to look for what ingredients do I need, remember again, see how I'm not looking at what surgery I'm doing or what technology I'm using. I'm first going by my planning. So now when I look at this, I'm looking at what is my dream ingredient here. I want something that I can put in this cornea that may hug the hex K area. So it stabilizes and corrects my astigmatism, plus makes my cornea more measurable in the center. Remember, center was clear. So I could do my cataract surgery intelligently and free her up forever. So I did a 2-ring intact in this, embracing the hex K. Of course, it's difficult, but it was something we had to do, go around these hex Ks exactly in that zone, expand the zone on the femto to form the channels, put the 2 rings there, correct her astigmatism down to 1.4, made her cornea measurable, waited about 6 weeks to 3 months to re-measure her many times to look for stability. Was able to measure her, got a nice reading on the lens, went inside the eye, did a toric lens, and she's 20/25 uncorrected without glasses. Again, what I want to emphasize, all of you can do this. All of you know how to do cataract surgery. All of you know how to do corneal surgery. It is not difficult, but see, the reason I'm trying to change your mindset is, if you had started with technology, you'd start talking, do I crosslink? Do I do intact? Do I do transplant? That's not the way I want you to think. Think about what is needed, walk backwards to your kitchen, pick up your ingredients, make a recipe just for this patient, and execute to perfection. Does that help, Eris?
Yeah, that's great, and quite an amazing outcome. I'm trying to remember, this was a patient that I saw, but I remember reviewing this case.
Yeah.
It's
yes,
quite impressive, just given where we started. So I will go over to the next, and we have some questions coming through too. So I want to make sure that we allow for enough time to get to those. Here's our second case. Could you walk us through this one, Dr. Gulani?
Absolutely. And again, please, the reason to show you this topography is not to dwell on the success, but to show you that I do not believe in mild, moderate, advanced, and that all these patients can see. I repeat what we said in the start. None of this is a guarantee to any patient, but it's a guarantee that we should have among ourselves as doctors that all these patients can be fixed. So here's a patient who flew to me with keratoconus, very advanced, if you may use that word again, 10 diopter astigmatism. Again, I don't look at topography, I start with refraction. I was able to refract him pretty accurately, but the vision endpoint wasn't great because if you can imagine that distorted a cornea, the visual glimpse out of that viewfinder, if you may, isn't as deciphering of the things it looks. It's distorted. So again, I looked at him, looked at his age, over 60, early nuclear sclerosis, high myopia, retina stable, no scar in the center. Where do you think I'm going? Let's now, for argument's sake, talk a little bit like most other people do, which is they talk surgery first and they come up and go, can we or cannot do it? I do not like that concept I'm repeating, because that's like saying, I have a burger and a burrito, what am I going to serve for dinner? Wrong. Be a master chef. Decide what ingredients can be put in unique recipes for each patient, and you'll always succeed. And the best part is you realize you are no longer slave to any technology because you can do it all. So in this patient, in my 5S system, I wanted something to stabilize the cornea, make it more measurable, again, because I'm planning cataract surgery in him. And this is pure keratoconus, nothing else going on before. Patient is over 60, more or less stable, so I'm not interested in cross-linking unless I have to. So you see how my brain is going into, I want stability, I want correction of astigmatism while stabilizing. At the same time, a welcome side effect that it's a measurable cornea for future cataract surgery. And we went with a single ring intact in this case, corrected the cornea, stabilized the patient over 6 months, proceeded with intraocular surgery to a very predictable 20/20 outcome.
Perfect. So I think this is a good spot. There were a couple of questions that came as they relate to the cases. And one of them was, what procedures were done in case one and in what order? And I'll switch over here to that case. if you could just run through that, and we'll do the same thing with case number 2.
Okay. So before I answer that question, because I get these questions every day in my emails from all over, from brilliant colleagues, I want to explain the concept first. Always explaining the concept. The order is very important. One of my article series in iWorld magazine is called GPS. They call it Gulani Planning System. GPS basically means you can't just start doing surgery or, for example, get into your car, step on the gas, see where you land. That's not how it works. First plan the destination, then get in the car and then take the best route to that place. So the destination here was based on my 5S system. The destination decided what I need to do. You never want to do intraocular surgery with a cornea that is insensible or unmeasurable, because then it's a disfavor. It's a disservice to the patient, because we're entering with intraocular surgery, which is lens-based, correct? Without knowledge of the cornea, which means our calculation of the lens is off. That's a complete disservice. I do not allow any surgeon to ever enter the eye if they do not know what the cornea is doing. So the sequence always has to be, this is also a concept in ophthalmology times I have given an interview, outside in, meaning cornea fixed first, measure it, go inside and do an accurate lens surgery. Now, please, there is another concept I've described, inside out. That's for different kinds of cases where somebody already had a cataract surgery, or you manipulate the optics with the intraocular lens, make the patient refractively an endpoint, which you can then correct with laser. So you slap it from the outside after fixing the inside. For these cases, it was outside in technique. You fix the cornea, make it measurable, use that for your lens formula, take it to perfection.
Perfect. So I assume that means intact rings to stabilize the cornea and followed by cataract surgery.
Yes, in this particular case. In other cases,
correct.
Absolutely. Yeah.
Right. And another subsequent question here is, how long do you typically wait in cases like these, whether it's inside out or outside in, from one procedure to the other for a stabilizing effect?
Lovely. And again, you see, Eris, how I'm going to, again, smash this question out, because I hate these numbers. There is no such thing as 1 month, 2 months, 3 months. Examine the patient every month. Refract them every month till you get a stability over at least 2 months that there's nothing changing. That's my answer. So ideally, I wait at least 6 to 8 weeks. Then I measure them myself repeatedly. Even if they've flown to me from out of country, I make their surgeon, wherever they are, repeat refractions and keep sending me. And remember, again, I did not say topography, I said refraction. So once they are stable, I want proof of stability at least over a month or 2 months. On average, it takes 3 to 6 months for stability in these cases. And remember, again, going back to one of your previous questions, Eris, you've already explained to the patient in cases where you're doing a staged surgery. Here's what I tell them. I'm going to take you to Paris, but in between, I'll take you to Timbuktu. Now, you have to have confidence in me that first we go to Timbuktu and you don't ask me why. Your vision might even get worse there because I'm planning for Paris. That's my endpoint. Now, on the other side of this discussion, you have to have the confidence that you don't crash your plane in Timbuktu because the patient was going to Paris. So it works both ways. Each of these steps has to be so accurately planned. Otherwise, you're heading down a spiral. You should be heading upwards. And the patient becomes, this is a side effect, the patient becomes your cheerleader because they know you're fighting for them. Does that make sense? I've added one more angle to what we do.
Sure. Education via analogies. I like it. So same question with regards to case number 2, as far as the treatment sequence here. Intact, you mentioned single segment ring to stabilize and then subsequent cataract surgery.
Yeah.
Got it. So with regards to intact ring sizes, and I'll head over to the questions. I just wanted to once again, remind everybody to continue to submit their questions here. But as it relates to the 2 cases, I just wanted to ask, this other question is, what size rings do you typically find that you use most in your keratoconus cases?
Again, I do not want to go into those details because once again, we'll take away from art. Today's webinar is, let's open up our minds. Everything works. I use mostly 0.45 because I want the highest ring for the highest impact, but we will not discuss that today. Today's main thing is, it's not even about intact. It's not about any surgery. It's about the fact that I want all of us to know how to do intracorneal channels, how to do 3 kinds of lamellar depth into the cornea, meaning anterior sutureless, anterior deep, deep anterior lamellar, and of course posterior, whatever you call it, DSEC, DMAC, your choice. You must know these surgeries. Intraocularly, you must know how to handle a phakic implant, toric phakic implant, pseudophakic lenses of all levels, not multifocal, but toric, trifocals, monofocals, all of those, including piggyback lenses and lens exchange techniques. If you can master all these, of course, laser surgery, you can master every keratoconus patient. Every patient will have a recipe that's unique to them. And I assure you, you'll be blown away by the fact that you thought they don't see. They'll all be seeing and hug you for life. All these patients. And topography, I repeat, is not. I get inundated with surgeons sending me topographies. I keep asking them, and those who have called me and spoken to me know, I will always ask them, did you refract the patient? Topography is a great adjunct to our knowledge. It is neither diagnostic nor does it tell you what to do. Very important. Please, please. This is a take-home point. Refraction and potential for vision.
That's great, and we'll sort of conclude the presentation portion here. Great. Okay, so with case number 1, please describe specific intact size and placement to achieve this dramatic 23 diopter cylinder correction. He appears, so I think we're just looking for some additional details on, the specifics of what was used as far as surgical treatment goes.
I will send you the video of this surgery, but today's talk is more about do not get impressed by the 23.5 to 1.4. That's just to show you that I don't believe in any keratoconus that cannot be corrected. So please, today's seminar is not about what I did. I will show you videos on this, including the exact details. But once your mindset opens up today, that's our success point.
Okay, does doing cataract surgery after the intacts affect the corneal intact?
No, it does not. Remember, again, your cornea is stable by now and was measurable. So now it's behaving like a cornea that's not changing, right? That was the reason you took the ability or the audacity to enter the eye and do accurate intraocular surgery. So you don't expect any change in cornea after that.
Perfect. So do you use, let me just see if I can read this a little bit more clearly here. Do you use intacts even in keratoconus patients who tolerate contact lens as well?
That is not even a question. Do you pick someone's bone if they're wearing a crutch very well? That's my answer to that question. If somebody is wearing a crutch, you have to sit down and give them options. Maybe they don't know. So contact lens is always an option, a super non-surgical option. But first, fix the bone. Here is why. I see numerous patients who come to me after wearing contacts for maybe 10 years. By now, they have apical scarring. The cone has progressed, and now they have crossed the levels of surgery, going straight to lamellar transplant. Is that answering the question, Arun?
Sure. So you must present them the options no matter. Now, with regards to the billing, I know that there's the caveat in where you need to show contact lens intolerance for billing purposes, but educating the patient nonetheless is important. Sure. So that
contact lenses wise, absolutely. In fact, let me point out, this is a very important point. Today, we are really blessed to have amazing contact lens technologies with the optometrists, and especially the scleral contact lenses that are a big boon to these cases. So let's say there are patients where you have worked on their broken bone. Let's say you did whatever, laser, intact, lamellar cornea, intraocular, and you still didn't come out to 20/20. A scleral contact lens is a tremendous adjunct your optometrist can add to take that patient to 20/20. Now let's take a case you just can't do anything despite trying. Again, a contact lens becomes a terrific adjunct. Patient is less than 21 years of age. You don't want to do any surgery. Contact lenses are a great way to make them see, go back to their life, live in sports, do everything. But to keep a patient in a contact lens in their productive stage of life and not address the problem underneath it, which is just being hidden, it's covering, not correcting, right? That is improper. You must fix the cornea, because leading them to a point by saying, I'm delaying your transplant, that is not a goal. I'm delaying amputating your leg. That's not a goal. Absolutely not. It is a problem that can be corrected. Cannot leave the bone broken underneath the brace. The bone is still broken. The patient is still disabled. Every night they remove their contact, they are disabled. So a contact lens is what I call a Superman suit. You put it on, you have a perfect six-pack. Behind it, you're podgy and completely horrible. So the point is to fix it. You cannot, this is a very important point, Arista. I love this question. Cannot give this option. You are the doctor. You decide. If the patient is not in the surgical age group, contact lens. If the patient had surgical approaches and failed, contact lens. Great boon, but cannot keep them in a contact lens and keep them disabled for life. Because there are options. That's the biggest part about today's webinar. Please take this home. You can fix these patients. They do see. Next question, Arun.
So in the speakers, this is our next question comes in and says, in the speaker's view, what is an acceptable amount of refractive error when there is the presence of irregular astigmatism on retinoscopy?
Mm-hmm. So no such thing again. To me, no limit. Just think about it. I just said this to you, right? If someone's in a car accident and their bone is broken in 20 pieces, does that decrease the desire that you have to fix it all? It does not. So there's no such question. That's why, in fact, I'm showing you, I have hundreds of these topographies, patients from 23 to 1, 28 to 0, all this. That's not important to me. I'm just showing this to you to make sure you don't talk about keratoconus as advanced and thereby don't approach it. So to me, I never look at these numbers. Like I said before when we started our conversation, let's say, first of all, the other topic I've just given interviews on into these iWorld and other magazines, I don't even believe there's any diagnosis called irregular cornea. Irregular cornea is a diagnosis as intelligent as upset stomach and bad headache. To me, it's a doctor who didn't go further to diagnose the real problem. Was it keratoconus? Was it a corneal scar? Was it a posterior corneal issue? If you diagnose, there is no such thing as irregular cornea. It has a cause, and that cause is treatable. So when I refract these patients, if I see irregularity to that level, my next step is I would put on a hard contact lens and refract them through it. Remember, again, I have all these topographies, but I don't look at it. I first refract. Then you will really see your potential. Once you got the potential, now correlate with topography as far as shape is concerned. And then attack in the 5S system. Let's call it 50 diopters irregular astigmatism. How does it matter to you? You just go all the way. Even if you get 30 out of it, that's mind-blowing to me. So please, there's no upper limit at all. In fact, this week I'm doing a patient with 19 diopter astigmatism post-RK. But the fact that he needs cataract surgery doesn't decrease my desire to go in with a toric lens that maximum it can correct is 6 diopters. But that gets me that much more, and then I have laser I can do on top. So I hope I've answered that question. There is no upper limit to the disaster. Please fight for it.
Sure. So would you consider cross-linking in between an intact and cataract surgery?
Again, pardon me, but again, I'm repeating myself. I just don't like anybody discussing surgeries like these. Would you do this or would you do that? First, tell me, why are you thinking of that? There's only one reason I may say yes to this. First of all, by putting the intact, we have already achieved stability and correction. Therefore, we have the audacity to go inside the eye for accurate surgery. Now, let's say you got a beautiful result with the intact or whatever you did, Ferrara rings or lamellar transplant, and you're stable and you're very happy. The patient has a super cornea, astigmatism corrected, and you're ready for cataract. Absolutely, you can cross-link, no downside to it. So I will allow cross-link over there only if you're suspicious for some reason that they may still change. And then remember, you're using it for my second indication, which is permanizing your corneal modification. So the answer is yes, you can, surely.
Great. Well, a final reminder to those listening in to that CorneaGen offers Intax and billing support. So you may direct any inquiries to intax@corneagen.com. And that completes the last of our questions. So over to you, Troy.
So not only do we thank you, Dr. Gulani, but thank you, Dr. Jordan. I do want to say that following tonight's session, we'll email you, the audience, a link to access the recording of today's webinar and a survey soliciting your feedback. We ask that you take a few minutes to complete the survey, as your comments will help guide us in presenting the best possible educational webinars as we move forward. So once again, many thanks to our phenomenal moderator, Dr. Arun Jordan, and our fantastic guest, Dr. Arun Gulani. I also want to thank you, our audience, for participating this evening. Enjoy the rest of your evening. Good night.
Thank you for having me.
Thank you for participating. Good night, folks.
Good night.